Good evening, everyone, and welcome to our chronic disease, kidney disease and diabetes webinar. My name is Helene. I'm the Workforce Development Officer here at West Vic PHN, and alongside me is Jade Buller. I'll be facilitating this evening. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First People hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. So that's up on the screen at the moment, and the link will be in the chat, so you can get that from there. Please see our upcoming events on the screen now, and you can register for these via our website, and the link will also be in the chat. Please make note of the West Vic PHN Health Pathways relating to this topic that is on the screen. Many of you will be familiar with these. It is a free online resource with localised clinical and referral information for health practitioners. A certificate of attendance will be emailed to all participants, so if you could take a moment just to check that your full name is displayed accurately on your screen. If not, or just rename yourself first and last name in the chat box. This will ensure we get the correct certificate and the name. Thank you. The event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question and answer at the end of the formal presentation. We do encourage interactivity and discussion, so please feel free to type in your question in the chat box at any time, and I will ask them on your behalf to the presenter at the end. Your feedback is also important, so if you could take the time to complete the event survey after the webinar, and there'll be a link to this in the chat. Our presenter for this evening is Professor Karen Dwyer, Director of Nephrology, Royal Melbourne Hospital. Welcome, Karen. I will now hand over to you.
All right, thanks, Helene. Welcome, everybody. I'm just going to share my screen now. Tonight, we're talking about chronic kidney disease and diabetes, and I'm calling in tonight from Wadawurrung country and pay my respects to elders past and present. This webinar, just to acknowledge that this has been developed in conjunction with Kidney Health Australia and the PEAK Committee, which is Primary Care Education Committee. So they review all the content that goes into these slides. Jade's gone through, Helene's gone through the housekeeping, so I'm just going to push on. So tonight we want to talk about the tools to drive early detection of chronic kidney disease in people with diabetes in the primary care setting, and discuss optimal management to slow or halt CKD progression. And the learning outcomes include understanding the importance of screening groups at risk of chronic kidney disease, who you should screen and how frequently, how do we do it, determine an individual CKD stage and why that's important, and then identify the goals for best practice management of chronic kidney disease, particularly in the context of diabetes. So I'm sure the first part of this is very well known to everyone, and what is CKD? So we define CKD by a reduction in eGFR, or estimated glomerular filtration rate, of less than 60 mils per minute that is present for at least 3 months, with or without evidence of kidney damage. And the with or without evidence of kidney damage is really important. So kidney damage may be the presence of albuminuria, and I really just want to stress the importance of detecting albuminuria, and that it really confers a poorer prognosis. So we'll come back to albuminuria a little bit later, but this is really the key. When somebody also has a reduced eGFR, we want to ensure that if there's any blood in the urine, so look for the presence of hematuria. And of course, if there's hematuria, it may be due to urological causes, but if there's not urological causes, we do need to think about some renal causes. There may be structural abnormalities, and often this will be seen on imaging tests and may be genetic and sort of have been since childhood. And then some people will have renal biopsy. In primary care, however, it's most likely going to be an eGFR, a urine, looking for hematuria, plus a urinary ACR that you're probably dealing with. So we have a few poll questions along the way, and this is our first one. So how prevalent is CKD in Australian adults? So if you can just pop what your thoughts are. We're getting a bit of a spread there. So we've got sort of 2/3 that have said 1 in 20, and 1/3 1 in 10, and somebody 1 in 5. So we'll close that poll. It's actually the answer is actually 1 in 10. So it is very common, and you will notice that it's actually 1 in 5 amongst First Nations Australians. So they're particularly at risk for chronic kidney disease. So 1 in 10 is actually is incredibly common. 90% of people, though, are unaware they have chronic kidney disease. So it's very much a silent disease, and as you know, you can lose a lot of kidney function before you develop symptoms. And so let's just think about the prevalence. We sort of highlighted CKD at 1 in 10. And then if we think about the sort of the pyramid of chronic kidney disease, we tend to focus on people with kidney failure. So these are people that are living on dialysis or living with a transplant, and they're very much that pointy end of the pyramid. And below them are the millions of people that have chronic kidney disease, whether it be stage 1 through to stage 5, and then those that are at risk, which is predominantly people with diabetes and hypertension. Of course, there's some other causes of kidney disease, but by far the majority is through hypertension and diabetes. So we need to be looking for people that are in these earlier stages of chronic kidney disease, because if we can intervene early, we can prevent that progression to kidney failure. And just to flag that of those that reach kidney failure, there's more people that die prematurely of heart disease than actually reach kidney failure. So it is those on dialysis or transplantation are really the survivors, because we've got such a high prevalence of cardiac disease impacting certainly beyond CKD stage 3, 4, and 5. So let's just sort of we'll work through a case, and hopefully some of the concepts around chronic kidney disease will become clear. So this is a 62-year-old woman of Indian background who works in a family catering business. She's previously been seen at your practice for the flu, and is overdue for an annual health assessment. Her medical background includes type 2 diabetes, which is managed with diet and exercise, and osteoporosis, no alcohol, never been a smoker, and she's on some medication for her bone health, calcium residronate, and she uses non-steroidals for occasional hip pain. At this visit, her blood pressure is 160 on 90. She has a height 152, weight of 70, with a BMI of 30. Now, as I'm sure you're all aware, BMI is not the most helpful tool in terms of ascertaining whether somebody's weight is more risky weight distribution or less. So we really do like to look at a waist circumference, and particularly that central adiposity is what we're looking for. So a BMI can sometimes be misleading, but we really want to understand where is the distribution of the adiposity. So best practice is to have the annual cycle of care for people living with diabetes. And if you have diabetes, we should also be checking kidney health. And in fact, kidney disease is more common than diabetes. And when you actually put diabetes and kidney disease together, it's a very potent risk factor for cardiovascular disease. So the other thing that I just wanted to flag at this point, if somebody has diabetes, it's really important to think kidney disease, but also think heart disease, because clearly these three things essentially always go together. And conversely, if you have somebody with kidney disease, check and see if they've got unrecognised diabetes, pre-diabetes, and they're most likely going to have an element of cardiac failure. Usually that the HEF, the diastolic dysfunction, where they've got the stiff ventricles. So who should we be offering a kidney health check to? So the majority of people with progressing to kidney failure have underlying diabetes and hypertension. So clearly anybody with diabetes, hypertension, it's a really good trigger to check their kidney health. Uh, a current smoker, vaping we know has a number of deleterious health effects. The central adiposity we were just talking about, established cardiovascular disease. It's interesting that, these so-called risk factors overlap very much with cardiovascular risk factors. So it just sort of again highlights the intersection of these conditions. In addition, if there's a family history of kidney failure, so if anybody's had a parent, grandparent who's been on dialysis, had a transplant, whatnot, it's always good to check. There's a lot of genetic components to kidney disease. If there's been a history of acute kidney injury, often there's a normalisation of kidney function, but that healing process does create scar damage or scars within the kidney. So certainly increases risks of future chronic kidney disease and, in fact, kidney failure. And in the absence of any of these risk factors, we would recommend offering a kidney health check to a First Nations Australian who is 18 years or over, and that's a recent change, and it really reflects such a high burden of disease in First Nations Australians. They get a lot of disease, it occurs much earlier and it progresses very quickly compared to non-Indigenous Australians. So we recommend screening at a very early age. In non-Indigenous Australians, in the absence of any of these other risk factors, we would recommend screening at age 60. Now, the question is about COVID, and certainly when we had a lot of COVID around and people were getting incredibly sick, we did see a lot of kidney disease arising following COVID. Now, that may have been in the setting of an acute kidney injury. But what I would say is that we're still learning a lot about COVID and long COVID, and there is some data to suggest that it does impact kidney function, but it hasn't so much been directly integrated into guidelines for screening. So how do we screen for chronic kidney disease? And it's actually quite easy. We have three components: a blood pressure check, a urine test for a urinary ACR, so that's a urine albumin to creatinine ratio, and a blood test for an eGFR. Opportunistic testing is fantastic. So do the blood pressure. We don't need it. We never need a fasting blood test. And for a urinary ACR, a spot urine is quite reasonable for that opportunistic testing. If it is negative, as in if the urinary ACR is normal, there's not an increased level, then you've got your answer. If it is raised, then it is important to do a second test. And on that occasion, I would suggest doing what we call a first void specimen. So first thing in the morning, take a sample, drop it into the pathology. The reason for that is there are so many factors that can impact and lead to a little bit of protein excretion in the urine. For example, heavy exercise, or we know that there are even some postural changes that can cause some proteinuria. So if it's positive, then it is best to check on a first void, but don't stop doing opportunistic testing, thinking that you must have a first void specimen straight up. In terms of how often to do a kidney health check, if you have diabetes, if you have hypertension, if you're a First Nations Australian, we would recommend doing that every year. If you've had acute kidney injury, we would suggest doing it each year for, say, the first 3 years. And for all others, we would suggest doing it every couple of years. So for Gia, her data is as follows. She has a blood pressure of 160/90, an eGFR of 55, and in the far column is the sort of the normal reference range. A urinary ACR of 23 milligrams per millimole, hemoglobin A1C of 7%, and a fasting blood glucose of 8. So, just so that you can recall the numbers, the question is, does Gia have chronic kidney disease? And we'll pop a poll up, and if you can just put your answer in. So we've got 3/4 are saying yes and 1/4 are saying maybe. So I'll just get that away. So the answer is actually maybe. So like with any diagnosis, we try not to put that label on on a single reading, whether it be hypertension, and same with kidney disease. So technically, we would like to repeat this and ensure that it's consistently reduced over that 3 months. So she does have a lower eGFR. It's under 60. If G has been in your practice before and you know that this is where her usual eGFR is sitting, then maybe you don't need to repeat it. But if this is the only reading that you have, then you may be asking a few questions. Is this an acute thing? Is it a chronic thing? How do I work out how to proceed? And that's what we'll go through now. So when we're looking at a CKD, there are 3 components. We want to take the eGFR. That's an important sign to give us a sense of the percent functioning, is often how I relay this to patients. We want to understand what's in their the urinary ACR. Do they have normal albuminuria? So in Gia's cases, it was less than 3. Is it micro? So that's a little bit of albuminuria, and we define that between 3 and 30, or macroalbuminuria, and that's above 30. And I always think it's really important to think about what could be the underlying etiology to give you that CKD diagnosis. And I think the underlying etiology is actually quite important, because if you've just used if you come up with CKD, sometimes it becomes very disconnected from what is driving it. So it's may become disconnected from the diabetes or the hypertension or the heart disease, and all of a sudden then we're treating 2 or 3 different conditions. But in fact, if we think about them as one condition, then we can harmonise and really streamline therapy. So the eGFR helps with the stage. The albuminuria gives us a sense of the degree of intrinsic renal damage, and the underlying etiology determines the cause of chronic kidney disease. So if we go back to Gia, and her first results are in the first column, second results, and then her third results at 3 months, and we can see that she's persistently hypertensive. The eGFR is quite stable in the low 50s. Urinary ACR is quite stable. Urinary ACR can fluctuate a little bit, and hemoglobin A1C again is reasonably stable. All right. So now that we've confirmed that Gia has chronic kidney disease, is it important to know the stage? That's great. So just about everybody has said yes, it is important, and that's correct. And the reason being is that understanding the stage of kidney disease will help with treatment decisions. It gives us a sense of, in particular, of risk for cardiovascular disease, and I'll talk a little bit more about that shortly. It gives us a sense of other complications that may be arising. We then work out when we need to perhaps refer on if someone's progressing towards kidney failure, for example. So the earlier we can diagnose someone and institute management, the impact is reducing cardiovascular disease, complications and morbidity and mortality associated with that. But importantly, we can now slow progression. And this is something that has changed in the management of kidney disease. Not that long ago, there wasn't much in our tool belt, and I can appreciate that for many people, it's why diagnose something if there's not a lot we can do about it. But that's really changed in the recent years, and there is a lot that we can do, and we can significantly slow the progression of kidney disease. And so if we can diagnose it early and manage appropriately, we can slow it as much as 50%. Okay, so the staging, and I'm hoping everybody is familiar with the heat map, and this can be really helpful. And it's a nice visual. So we've got eGFR down the y-axis on that left-hand column, and then we've got the degree of albuminuria or proteinuria across the top. So normal, micro, or macro, and we take a line down the eGFR. So eGFR was in the low 50s, and the urinary ACR from memory was in the 20s, and so GIA sits in the in this orange box here that is circled. Now, the yellow, the red, the yellow, the orange, and the red, this traffic light system, it's a really useful thing to remember, because the yellow or green really suggests that there's no increased risks associated. Really, we've got normal kidney function at that point. We don't have any proteinuria. When we have yellow, we have a low risk of progressive kidney disease and of cardiovascular disease. In orange, we have a moderate risk of progressive kidney disease and cardiac disease. And in the red, we have a very high risk of progressive kidney disease, but also high risk of cardiovascular disease. So two things I just want to flag here is that both cardiovascular disease and progression of kidney disease, they run parallel in terms of risk. And I also wanted to flag here in the red that you can have a preserved eGFR, but with significant proteinuria, your risk is really high. And this is what I come back to right at the very start, the importance of the urinary ACR. And we know that across the board, and this is primary care, but also in tertiary care, there's a big practice gap in terms of screening with urinary ACR, and it's often not done. And so if there's one thing to take away is doing the urinary ACR is a really important investigation. So if we wanted to diagnose Gia, we would say she has CKD stage 3A. She's got microalbuminuria, or could be said as A2, and that's most likely due to underlying diabetes plus or minus hypertension. They obviously go hand in hand, so probably together. Now, when you've diagnosed and looked at the use that heat map, you can then look at the CKD management handbook that comes from Kidney Health Australia and go to the orange action plan. If somebody was located in the yellow, you'd go to the yellow action plan, and similarly in the red, you go to the red action plan. And each one builds. So we have sort of the first stage of management in the yellow, then we build into the orange, and then you build further into the red. There's also the CKD Go app, so you've got the same information that you can just put into an app on your phone. It's really helpful if you can enter reminders into your software to be, checking again in every 3 to 6 months, for example, for frequencies of reviews for Gia, given that she falls into the orange box. Does a diagnosis of CKD have any implications for Gia? I don't think we need to sit on this one for too long, given that I've just been talking about the impact of chronic kidney disease. So of course, yes, it does. And so we've talked a little bit about the association with heart disease, but just a 20-fold increase in heart disease, and that impact is across all ages. So the younger somebody is with kidney failure, their risk of heart disease is so much greater than the age-matched population. In the older population, it's still increased, but as we know, older people have more heart disease as well. We know that around 20,000 Australians die every year with kidney disease, and the impact of kidney disease on a sort of a social, occupational level is very significant, particularly if somebody ends up on dialysis. CKD contributes to 1 in 6 hospitalisations, and in terms of the number of people that have reached kidney failure, that's more than doubled in only 20 years. So we've gone from about 11,000 to nearly 30,000 people that are either living with a transplant or on dialysis just in 20 years, and the projection is greater. So I've touched on this before. So we call this, make the link, and we've got shared risk factors. And in fact, we've really got a lot of shared treatments. There's some nuances, and hopefully one day we'll get some harmonisation of those sort of nuances for diabetes, chronic kidney disease, and cardiovascular disease. But there is a lot of overlap. So, another thing to take away: if anybody has diabetes, think CKD, think heart disease. Anyone with CKD, think diabetes, heart disease, think those two, because they often, more often than not, they go hand in hand. So what treatment interventions would you discuss with Gia? And there's lots that you can pick from there. It doesn't just have to be one. So we're talking about lifestyle. We've got antihypertensive, oral hypoglycemics. Is it time to refer to an endo or refer to a nephrologist? Yeah, great. So, of course, lifestyle modification, I love that's been picked by everybody. Most would think about an antihypertensives. Most are thinking about an oral hypoglycemic agent. There's a few that are thinking about referring to a nephrologist, and we can talk a little bit about that shortly. So I would agree, perhaps not refer to a nephrologist, but if you're unsure, it's best to ask, isn't it? So, nutrition and diet or lifestyle modification, behaviour changes absolutely underpins all of these chronic diseases. So, it underpins diabetes, heart disease, kidney disease, again, that intersection. So, we really need to be thinking about fresh, seasonal, whole foods are going to be a really good dietary approach for someone with chronic kidney disease. We shouldn't be trying to limit protein intake, and that previous teaching, I think, has probably led to a lot of malnutrition. So, we shouldn't be trying to restrict protein. We need fresh whole foods. We want, uh, uh, vegetables when needed. Vegetables. Healthy fats and, of course, some, spices and whatnot for taste. So we know that sort of approach, and in particular, avoiding ultra processed foods and lots of sugar, is going to improve kidney function, improve diabetes control, reduce weight, improve blood pressure. So it's absolutely fundamental. We want to make water our drink of choice, and certainly avoiding things like juices, soft drinks, energy drinks, flavoured milks, all those things that are just really high in sugar. So Gia has hypertension. What would be your target blood pressure? That's great. So we've got sort of 2/3, 1/3, 130 on 80, 120 on 80. So I think this is a little bit, it's maybe a bit it's becoming a bit controversial or up for discussion. We still have our target blood pressure of less than 130 on 80. However, as those that perhaps indicated the 120 on 80, there has been some recent large studies, in particular the SPRINT trial, that suggested even lower. So 120 on 80 was advantageous. And I must say this went through a lot of discussion with the peak group as to what we should set as a target, and we've maintained the 130 on 80. Clearly, we want to be personalising, tailoring blood pressure targets to the individual. And there may be certain people where we do need to push that little bit harder to 120 on 80. And conversely, there may be people where even going to 130 on 80 is not going to work. And I'm thinking particularly of someone perhaps that's frailer and maybe at risk of falls, for example. So I think if we can get to 130 on 80, we're doing really well. There may be some that you do want to push that little bit further. So we've just talked about that and treatment targets. So in terms of what to use in chronic kidney disease, so ACE inhibitors and ARB, so RAS blockade has been sort of the backbone of our management plan for many years now, and up until recently it was about all we had in the toolbox. So we still recommend this as first line therapy for people with chronic kidney disease. That's with or without diabetes. And as I'm sure you all know, when you first initiate treatment with an ACE or an ARB, you may see a drop in eGFR, but that means that the medicine's actually working. So it drops that pressure across the glomerulus. We expect to see a small reduction in eGFR. I always like to check I always like to check electrolytes, a UE, use and ease, within 2 weeks of starting therapy. Often it's somewhere between that 7, 7 to 14 days, and often it's around 10 days, somewhere in the middle, just so that I know that they're able to tolerate it. If it's a big drop in eGFR, then you should stop the RAS blockade, and you may then want to refer on, because we then worry about things like renal artery stenosis, for example. As you know, RAS blockade can increase serum potassium, so you just do need to be mindful of what the potassium is when you start an ACE or an ARB. And we don't recommend combining ACEs or ARBs, so it's one or the other. I don't have a particular preference. As you know, some people do get an irritating cough with an ACE inhibitor, and often that's better with an ARB, so you can switch that over. There's a lot more information on this in the CKD handbook, so the 5th edition, which was launched about this time last year. So we start Gia on an ACE or an ARB, and she comes for her 3-month follow-up. She has been working on some lifestyle measures. She's trying to increase her vegetables and reduce her carbohydrates, so that it's going to be better for diabetes. She started doing some walking, so that's terrific. We started an ARB, and we also started metformin as an oral hypoglycemic agent, given that her hemoglobin A1C was 7% or 7.1%. But she's still really not at target. So so it was 7%, so our hemoglobin A1C is still around that 7.1%. So we probably need to try and improve the glycemic control a bit better. What would be your second agent, whilst we keep advocating lifestyle? Okay, so that's interesting. So 80% SGLT2 inhibitor, somebody suggested a sulfonylurea, and someone suggested a GLP-1 receptor agonist. So I think the data's and the guidelines are quite clear now that we should be thinking about organ protective agents. When we're talking about managing glycemic control, it's not all about reducing the blood glucose. Clearly that's important, but we do want to think about end organ protection, in particular heart and kidney. And the data is overwhelming now that SGLT2 inhibitors offer that. And in fact, we use SGLT2 inhibitors now in the absence of diabetes, in kidney disease, and also in heart failure. I think there's no real reason to use sulfonylureas now. I think there's so many adverse effects with sulfurs that I take any chance I can get to stop a sulfur. There's the weight gain, there's the risk of hypoglycemia. So SGLT2 inhibitor, GLP-1 receptor agonist is a really interesting one, and clearly there's some emerging organ protective data. We know from a heart perspective, and also in the kidney space, that's emerging. Probably not yet in that sort of first line of agents. And in fact, you can now start SGLT2 inhibitors straight up with metformin. There's been some PBS listings. So I think the SGLT2 inhibitor would be a sensible approach in this instance. Although, as others have pointed out, there are other agents that would reduce blood sugar level. So just a little bit about some of these medications in the setting of diabetic kidney disease. So metformin still remains the sort of backbone of glycemic management. When you do have reduced eGFR, you just need to be wary of metformin, and it's not because it causes further kidney damage, but it's that risk of lactic acidosis that can occur. So when an eGFR is below 60, so 45 to 60, we recommend just reducing the dose a little bit. And then under 30, we often would suggest stopping metformin. Now, that's not because at an eGFR of 25, metformin is going to cause an issue, but when you've got an eGFR of less than 30, clearly, if there's another illness, for example, acute kidney injury or acute on chronic injury can occur, and that's the thing that precipitates a lactic acidosis. So it's being wary that there's just not a lot of reserve once you start to get to these lower eGFRs. Like with a lot of the agents we're going to talk about today and what we've talked about with RAS blockade, we do just need to remember a sick day management plan. SGLT2 inhibitors, so being widely used now amongst with diabetes, but with also kidney disease. We can use these down to fairly low eGFRs. So dapagliflozin, eGFR 25 is the cutoff, and EMPA is 20. So they're just good numbers to know. There is a trial on at the moment looking at dapagliflozin with people on dialysis and also living with a transplant. So we'll get a little bit more information. With both of these, there's just a few things to be wary of when you're prescribing. So there will be another drop in eGFR, which we'll talk about in a bit more detail. I always warn people about it's not common, but that risk of genital thrush, which is just pretty yucky and hard to treat. So I warn them that if they get red or itchy, just stop it, and you may be able to try it again. But I think that's just an important one to be aware of. The risk of euglycemic ketoacidosis is it's just worth pointing out. We know that about I think it's like 1 in 10 people with type 2 diabetes actually have very little insulin, so they're probably unrecognized type 1, and they're the people that are at risk for euglycemic ketoacidosis. Again, the sick day management plan is important, so stop during periods of illness. It's the illness and it's the low insulin that precipitates a euglycemic ketoacidosis. So if you don't have diabetes, you're not going to get ketoacidosis using an SGLT2 inhibitor. You do need both of those factors. So sick day management plans are really, really important. The gliptins still do have a role in the management of diabetes. Clearly, if you're using saxagliptin or vildagliptin, we have an eGFR. You want it to be above 15. There's no dose adjustment with linagliptin. It's just 5 milligrams across the board, so that makes it easy to remember. Sulfonylureas, as I mentioned before, I really don't like them, and because I see a lot of people with advanced kidney disease, I'm trying to get rid of them anyway because they're slow to metabolize, and so the greater risk of hypoglycemia. We've talked a little bit about the GLP-1 receptor agonists, and so again, advanced kidney disease is an issue, but the renal and cardiovascular benefits I think are real. Insulin may be required, of course, so that's titrated to blood sugar, just to be aware that as eGFR declines, you may not metabolize the insulin, and so risks of hypoglycemia as well. At the bottom here is non-steroidal MRA, and we're going to talk a little bit more about this agent in a moment. So this is finerenone, or Kerendia is its trade name, and this doesn't impact glycemia, but is important in diabetic kidney disease, and we'll talk about that a bit more shortly. So SGLT2 inhibitors. So there's a streamlined code for diabetes, but also for chronic kidney disease. The one there, 13230, is for chronic kidney disease. To prescribe it, an eGFR between 25 and 75, we need a degree of proteinuria, so greater than 22.6 milligrams per millimole, and you must have been on a RAS blockade for about 4 weeks, unless not tolerated. So that's really all that's required for PBS listing for SGLT2 inhibitor. I don't know why that's there. So I mentioned before there is a reversible drop in eGFR after commencing an SGLT2 inhibitor. The nadir is at 4 weeks. With a RAS blockade, I mentioned I would test at 10 days or 2 weeks. When would you test once you start an SGLT2 inhibitor? So it looks like we've sort of got 8 weeks, 12 weeks not required. I'm glad nobody said 4 weeks. So essentially, it's not required. So it's quite different to the RAS blockade, where I'm doing a specific user needs to see what's happening after starting this medication. I definitely don't test at 4 weeks because I know that's when it's going to be at its nadir. And so I only test when I would next schedule a test. What I do though, in the lead up to starting an SGLT2 inhibitor, because I know that often this drop in eGFR, part of it's hemodynamic, but part of it is volume loss because you're blocking the SGLT2 receptor, you've got glycosuria, you actually do lose some fluid. I may reduce some diuretics as I start SGLT2 inhibitors, and that sometimes helps in terms of just lessening the impact on renal function. So this is a very well characterized graph now. And so this is the starting of the SGLT2 inhibitor. We see this drop. Its nadir, as I mentioned before, is at 4 weeks, and then it slowly rebounds. And then over time, we can see that the rate of decline of eGFR is a lot less than placebo. And this is what's translated into SGLT2 inhibitors becoming really a renoprotective agent. And this is just some modelling that was done based off some of the early data. If we had our starting point, which was the average person in one of the first trials called Credence, so they had an eGFR of 56 mils per minute, you can see with the addition of an SGLT2 inhibitor that you're potentially delaying reaching end-stage kidney disease by, sort of 15 years. So that's really significant if it's you that has that eGFR. I'm just going to talk a little bit about finerenone because this is still relatively new. So it's a non-steroidal MRA. I'm sure most people are aware of steroidal MRAs such as spironolactone, but this one's a non-steroidal. So it blocks the mineralocorticoid receptor, and we know that this receptor actually is overactivated, and that it probably is driving a lot of the inflammation and fibrosis. So now with RAS blockade, with SGLT2 inhibitors, and now with non-steroidal MRAs, we've sort of got this pillar approach, again, very similar to what's being discussed in heart disease and kidney disease with these pillar approaches. RAS blockade is very much the hemodynamics. SGLT2 is very much the metabolic, bit of hemodynamic, but very much the metabolic. And MR is, or non-steroidal MRAs are very much the inflammation and fibrosis. There's been a number of studies that have really now shown that it's renoprotective, and there's interesting work coming out in the cardiovascular space as well. This agent is also PBS listed, which is great. That it follows the same criteria as an SGLT2 inhibitor, so that's really good. Except the only difference is you need to be on the RAS and the SGLT2 inhibitor, and then you add on the non-steroidal MRA. But the other components are the same. So eGFR of greater than 25 mils per minute, a urinary ACR of greater than 22.6. So it sort of builds the pillars for us: RAS blockade first, SGLT2 inhibitor, then non-steroidal MRA. And then we've got the GLP-1 receptor agonists. And just to touch on this, because this is relatively new data from the FLOW study from last year. And again, it just really showed that we get this little dip to start with, but then the use of, in this case, semaglutide, the rate of progression of kidney disease was a lot less. So the slope of eGFR decline hasn't been shown outside of people with diabetes and chronic kidney disease. So that's different to what we've seen now with the SGLT2 inhibitors, and not yet PBS listed for renoprotection. So would you refer to a nephrologist? So we touched on this before, didn't we? So most are saying no, maybe, and yes for a couple of people. And it is maybe. And it really depends on a bit more of the nuance of this case, doesn't it? This is the referral guidelines or algorithm that comes from the CKD handbook. So that's on page 74. If you've got someone that's got a rapidly changing eGFR, absolutely, this person needs to be seen, you probably don't even refer as an outpatient, you refer to ED if someone's got a rapidly changing eGFR. If they haven't, and their eGFR then is below 30, that may be a prompt, or should probably be a prompt to refer. If the eGFR is greater than 30, but they've got a degree of proteinuria, that may be a prompt to refer. So it's quite a nice algorithm there. It can be a little bit complicated, but really, I mean, if you're worried, clearly you get some advice. Rapidly changing, get into ED. eGFR, I have a little bit of a concern of just saying eGFR less than 30, refer, greater than 30, don't, because it is contextual. So if you've got a young person with an eGFR that's, say, 50, that might make you refer earlier than perhaps if you've got someone that's in their 80s and their eGFR is 29. So, I think we need to think about the context and what else is happening for that person and their age. But that just gives you a little bit of a framework to work from. So coming up to the end, which is good. So take-home messages, early diagnosis is important. And for that early diagnosis, we really need that urinary ACR. And that's the thing, if we remember the heat map, it's the degree of proteinuria that really ramps up someone's risk for progression. You really want to be able to identify people at risk. So think, who should I be offering this test to? And then there's things within your practice software that can help you with alerts and whatnot. Think about our management pillars, which is RAS blockade, SGLT2 inhibitors, non-steroidal MRAs, our blood pressure targets, and glycemic targets. Kidney Health Australia has lots of health resources for patients, but also for clinicians. So there's lots of resources there that you can direct patients to. There's very practical stuff, so dietary stuff, as well as a lot of information for patients. And then just to also highlight, there is a Kidney Health Professional Hub, and so if you wanted to join that, and you get access to lots of the Kidney News, which is a newsletter that's sent out. There's webinars, there's on-demand education, and other resources. So it's quite a handy thing to have access to as well. And questions.
Thanks, Karen. I don't have
Nice.
any questions at this stage.
Nice.
If anybody's got any questions, just type them in there, or you can take yourself off mute and ask the question for Karen. So we've got a little bit of time if anyone's got anything they would like to comment or ask. A couple of questions coming in, Karen. Can you please explain the EDKA and SGLT2I mechanism in more detail?
Okay. Please explain the SGLT2 inhibitor in mechanism. Oh, the EDKA. Oh, and mechanism. Okay, sure. So, at least in mouse studies, what has been shown is that for euglycemic diabetes ketoacidosis, you need two components. You need an absence of insulin, and you need infection or sepsis. You need to be unwell, or volume depletion, I guess, is the other way to think of it. So it's a lack of insulin, and it's the illness that precipitates. So of all the big studies now, there's been a meta-analysis looking at the risk of euglycemic diabetes ketoacidosis. If you have diabetes, there is about a twofold risk of DKA with an SGLT2 inhibitor, hence the importance of sick day management. If, however, you don't have diabetes, I think there was something like 7,000 or 10,000 people in this meta-analysis, and there was one case of DKA without diabetes, and that was somebody that was very unwell in hospital. So lots of other things going on. So essentially, if you don't have diabetes, there is very little risk. But if you have diabetes, the question is, do you produce enough insulin of your own to prevent a DKA or not? So that's my understanding of the euglycemic diabetes ketoacidosis. Initially, everyone's very, very concerned about this, but it's not. I don't think it's as common as what we first believed, but I think that sick day management plan is absolutely critical. And I tell them about the potential for thrush, and I use the sick day management plan. There is a template through Kidney Health Australia on their health professionals hub if you actually want a sick day management plan template.
Thank you. Any more questions? You can take yourself off mute. While we're waiting, please don't forget to fill out your evaluation. Any topics at all, we will be partnering with Kidney Health Australia again in the next couple of terms. So any topics related to kidney health, pop them in there. I'll see if we can address those for you. If there is no more questions, I will take this opportunity to thank you, Karen. Great presentation as usual. It's always a pleasure to have you speak to our GPs and everyone. So thank you everyone for tuning in, and we'll see you next time.
Thanks everyone.
Thanks,
Enjoy your night.
Karen.